Well, welcome everybody. Welcome to the Young Dementia Network webinar. I'm Tessa Guttridge. I'm chair of the Young Dementia Network and host today. And with me is our presenter, Dr. Clarissa Giebel, Senior Research Fellow at the University of Liverpool. Behind the scenes, we've got Catherine making sure that everything runs smoothly for us. And then Kate is going to join you on the chat, add useful links for us. Reminder to you that you're not on video or audio, so please do use the chat function. That would be great. But also do add questions to the Q&A box, and we'll protect some time towards the end for Clarissa to respond to those questions. That would be great. As always, we start our webinar with a short film of Catherine in conversation with Chris Maddox on the topic of misdiagnosis. Thank you very much to Chris for your time contributing to this. I'm going to ask Catherine now to start the film.
I'm delighted to be joined here by Chris Maddox, who was diagnosed with young onset dementia at the age of 60. Thank you, Chris, for being here to share your experience with us. During this webinar, Dr. Giebel will be discussing her latest research in misdiagnosis. You had your own experience of this when you first noticed symptoms. Are you able to tell us a little bit about that experience and what the impact had on you?
Yeah, sure. I was diagnosed at the age of 60 with early onset vascular dementia. I was still working full time, and this was following the 3 minor strokes that I'd had, which had also left me with some cognitive problems. So my GP just kept saying, oh, it's because you've had a stroke. My GP one day told me she was there for my physical health and not my mental health. And there was another glitch because I moved from Wales to England and I had my diagnosis in Wales. So when I moved to England, for 4 years, I was asking the GP if I could see a neurologist in England because my symptoms were changing. And there were things like I lost my sense of taste and smell, and that was before the pandemic. I had terrible restless legs. I was sleeping really poorly. So I knew there were changes, but I was putting it all down to my Parkinson's disease, which I was diagnosed with that 2 years after my vascular dementia. So, yeah, it's not an easy process. But after 4 years of asking my GP if I could see a neurologist, I was referred to see a neurologist in England. And I had another scan, a CT scan. I was examined and I spoke to the consultant. And at the end of it, she said, I think that you may have Lewy body dementia. So I said, what do you mean you think I may have it? Do I or don't I have it? To which she replied, it can only be confirmed on autopsy. And I said, well, I'm not ready for that yet. And I've since found out that it can be confirmed with a DET scan or a PET scan. And when I asked for one, they said it would cost too much money, so I didn't have one.
Yeah, that's really hard to not have the knowledge of what it was. And what impact did it have on you to have a sudden change of diagnosis?
Well, it was huge because I went there expecting just to be told there were changes in my brain scans and what the changes were. So I really wasn't expecting a totally different diagnosis. And I knew nothing about Lewy body dementia. I knew lots about vascular dementia. I was fortunate enough that there is the Lewy Body Society, so I went there for some help. And they now have 2 admiral nurses working for them, specializing in Lewy body dementia, but I had to find these things out for myself. I wasn't given any information about Lewy body dementia. I wasn't, referred to any onward services, and I wasn't given another appointment with a neurologist. I was diagnosed and discharged.
It's not good enough, is it?
No,
to not have that support.
And you're supposed to have annual checks about your dementia. It's 7 years now and I haven't had one annual check. So you literally are left to fight your own corner if you can do so.
Yeah, that's really tough. And if you had the diagnosis of Lewy body dementia earlier on in the process, do you think it would have made a difference to you and your family to have that diagnosis?
I think it would have made a difference to me in as much as the understanding of Lewy body dementia and the effects of Lewy body dementia. Because, you know, I understood then vascular dementia, and there's lots of sort of, they say Lewy body dementia is the second most popular kind of dementia, but it's the least diagnosed. Because it's harder to diagnose Lewy body dementia. And one of the main symptoms is hallucinations. Unfortunately, I don't get them. But it's nice to know what's ahead of you.
Yeah.
And I'm one of these, I try to work, if there's a glitch or a problem, I'll try and work a way around it. Yeah, so it's trying to make things better for yourself, but you can't make things better for yourself unless you know what you're facing.
Yeah, yeah. So it's important to understand that correct diagnosis to know what's possibly in the future.
Yeah.
So what improvements would you like to see in terms of the experience of diagnosis for people and people with young onset dementia?
Where do I start and where do I stop? First of all, there's got to be faster, quicker routes to get a diagnosis.
Yeah.
I think the average at the moment is about 4 years to get a diagnosis. So what happens in those 4 years before you receive a diagnosis?
Yeah.
I lost my job as a result of my diagnosis, and I got no support in anything.
Yeah.
I tried to claim benefits and I couldn't get benefits, so I had to take them to a tribunal. How many people are able to do that?
Yeah. Yeah.
And I think that once you receive a diagnosis of dementia, and if you are a younger person and you lose your job, whatever, there's entitlements that you're entitled to. You know, there's the personal independence payment and employment support allowance. But I literally had to fight to get what I was entitled to. And it shouldn't be like that.
No. So
I had the shock of having a diagnosis, but I also had the emotional and financial impact of losing my job as well.
Yeah.
So I would certainly like a faster route to getting a diagnosis. And when I've had the two different diagnoses, it was so matter of fact the way that the diagnosis was delivered. It was a case of, you've got dementia, go and get your affairs in order. And I would much rather than give you some hope when you receive a diagnosis and saying things like, well, there are some things you may not be able to still do.
Yeah.
However, there are lots of things that you can still do. Because I think people get this diagnosis of a life-limiting, life-changing condition, and to not get any hope or encouragement. And I can remember sitting and thinking to myself, you've got a choice. You can either sit and vegetate, or you can do something with what's left in the rest of your life.
Yeah. And so you've chosen to, try and raise awareness with young onset dementia.
Yeah,
speak out
absolutely.
to people and the experience you're having to try and make a change, which is amazing.
I just want to raise awareness, and if I can make things better for other people getting a diagnosis, to not have to go through some of the awful things and the pitfalls that I went through, it's all worthwhile for me.
Well, thank you very much, Chris, for everything you do and for being here to share your experience with us. Thank you.
Thank you.
Thank you very much. The importance of an accurate diagnosis, giving confidence around and knowledge and information to the person and the family, was expressed really well by Chris, wasn't it? And that ability then to be able to mitigate the impact as much as possible and know what you're facing, I think that was really well expressed in that video. So thanks, Chris. Can we welcome back Clarissa? And I'm going to hand over straight away to Clarissa for her presentation. And just a reminder to everybody to pop your questions in the Q&A, and we'll come to them later. Thank you. Over to you, Clarissa.
Right, thank you so much, Tessa, and the organization for inviting me. I'm just going to share my slides. Just bear with me, organizing my Zoom screen. Can you see the main slide or my presenter slides, Tessa?
I think you need to move to the
So you can see the presenter slides, yeah.
Yeah.
Okay, it's better, right. So thank you again. Pleasure to be here.
And Larissa, that's it. Yeah, thank you. It's just come. It was a slight delay.
Okay,
That's fine.
So thanks for Chris Maddox sharing her insights as well. We've met actually in May at the Alzheimer's Society conference. It's really important to hear from people with a lived experience as well, for us as researchers and for anyone. So today I will be giving a little talk about misdiagnosis of dementia and specifically findings from a very recent systematic review. So the research that I am doing and my team is doing at the University of Liverpool is focusing on all things surrounding inequalities in diagnosis and care for people living with dementia. So this was a collaboration as part of a European network called INTERDEM. So before we start diving into the findings from the systematic review, I just want to touch upon some of those many inequalities or inequities that people living with dementia and their family members and unpaid carers can experience. Now, here you see a slide of some of the frequently mentioned and evidenced factors and barriers that people can experience when they're trying to access a diagnosis and or when they're trying to access post-diagnostic care. And some of you might have seen recently a report from OAG in collaboration with the Alzheimer's Society that has stated that there are 110 inequalities or barriers to diagnosis and care. So a lot of our work focuses on what we call intersection of those different factors, because it's not necessarily that someone is only experiencing difficulties because they are from a minority ethnic background or because of where they live in a rural or urban area or suburban area or north or south of England, etc., or availability of an unpaid carer, for example. These factors are often interlinked or intertwined, and we tend to break these down on a personal and individual level. Another level is how people are interacting with their peers and families and community. And then there's a third overarching level where people can experience difficulties and barriers, and that has to do with the health and social care system. So, for example, there's often a great lack of care professional knowledge, of communication, lack of information provision. So this is kind of the backdrop. And just to highlight, some of our research during the COVID-19 pandemic has specifically looked at how people living with dementia and their unpaid carers might have been affected by the pandemic in terms of accessing care. So we looked at social care services in particular. What do we mean by social care services? That includes receiving home care, receiving daycare, going into a care home, respite care, accessing support groups. And it showed that whilst a lot of people are already struggling to accessing social care before the pandemic due to financial needs, lack of information, age, service suitability, etc., the pandemic has caused even greater difficulties for many to access them and for people to go back to them throughout the pandemic time and since. Another thing is that as part of our European work, again, just to provide some context before we delve into the misdiagnosis, is that we work across Europe with academics, but also with the European Working Group of People Living with Dementia and the European Working Group of Carers, who are supported and facilitated by Alzheimer Europe. The aim for us in Liverpool to work with people across the UK and across Europe is to understand better what are those difficulties that people might experience when they have a diagnosis or not a diagnosis yet, and their families in Germany, Netherlands, Italy, etc. And are there maybe any good practices who reduce inequalities and improve access to diagnosis and care from those different countries? So we've recently done a survey with academics and people living with dementia and unpaid carers across 10 different countries in Europe. You see the countries listed here. And we've also held consensus meetings. Now, they were held in person, and they were with people affected by the condition and health and social care professionals, and to sit down and really sift through those inequalities. And those blue boxes you see at the bottom here, those were the key factors, the key barriers that were highlighted repeatedly across those different countries. For example, lack of information, a lot of stigma, particularly for people from minority ethnic groups to approach a GP, lack of clear communication and workforce training and knowledge, etc. These are some of those factors. So within our European, what we call task force, working group, we then looked at the findings of this survey, and we wanted to hone in on a particular topic to work collaboratively together. So what did we focus on? We focused on the correct and timely diagnosis. And this is an issue that comes up a lot within our research group at the University of Liverpool. And in a public forum that I'm running, the Liverpool Dementia and Aging Research Forum, because we very often get together with people with lived experiences and care professionals and charities. And for example, the Lewy Body Society is a very frequent collaborator of ours. And they very often say it's such a difficulty for people to receive the right diagnosis and not to wait for several years, as Chris was saying. So if we're looking out there, what might impact a correct and a timely or less time-intensive diagnosis? There are some reports, for example, by the Alzheimer's Society. We know there's some regional variation. We know that there is differences in workforce knowledge. Oftentimes, GPs might not recognize that someone might have dementia symptoms from frontotemporal dementia, Lewy body, young onset, etc. People from minority ethnic backgrounds might not approach their services to receive a diagnosis. These are some of the factors that we were aware of from the evidence. And we also know statistically across the UK that only about 2/3 of people who have dementia actually have a diagnosis. Now, statistics differ a little bit, and they also differ by region within the UK. But on the whole, we know that there's a lot of missed opportunities for people to have a diagnosis. And diving into the different subtypes of dementia, we know that there's particularly difficulties for identifying those different symptoms to receive the correct diagnosis. So we have now specifically focused on those different subtypes, and as part of this, obviously also on young onset dementia. So I'm sure many of you are aware of the different subtypes. It's a really nice infographic by Kate Swaffer. I like to use it's just to highlight really dementia is the umbrella term, and there are so many different subtypes. Even within other dementias, there are so many different variations, and this is not all. Obviously, there's the age factor included in that as well. Just to show that even though we have an estimated 1 million people living with dementia in the UK, that doesn't mean they're all the same. Even not by the diagnosis, all of them have different needs, different preferences, different wishes for care, etc. So how did we approach this topic? In research, we often tend to conduct a review of the literature if we're touching upon a topic that we as a group haven't maybe worked on together before, or if we have a question that we really want answering, but we haven't received any funding to conduct the research yet. So, by the way, this is currently under review with a journal. So this is not even hot off the press. This is hot off before the press. So it's good to share this and also to hear people's thought about the topic. So what did we do? With this systematic review, we looked at studies that were published on 8 different databases, so the more the better, because we reach more articles, more evidence. Searches were conducted in June 2023, and we looked at evidence that was published since 2010, all with a focus on synthesizing the evidence on misdiagnosis of dementia. Now, what did we mean by misdiagnosis? One was if someone received, for example, a diagnosis of Alzheimer's disease dementia, but then subsequently received the correct diagnosis of, say, Parkinson's disease dementia. The second angle of misdiagnosis we included, but didn't necessarily find much evidence on, was if someone was diagnosed with depression in the first instance and then diagnosed with dementia, as an example. So the evidence we found was really only on those subtypes, which is interesting in itself. So here you see a little bit of a flow diagram of what we've done, what we've looked at as a team. So we screened over 4,300 titles and abstracts, so those 250, 300 words abstracts. We found that 97 studies might be suitable. So we went through all of them within the team, and then we decided, based on what's written in the evidence and the methodology, we included 20 studies. 16 of them were quantitative, so that means they had survey findings primarily, and 4 of them were qualitative, so conducting interview focus groups. Of those quantitative studies, there were also quite a few that looked at what we call big data, or data that's within an NHS setting that people can utilize, for example, and have access to. And this can be really important because it doesn't mean researchers have to go out and collect the data, but the data already exists for years and years and years on end, so we can revisit that data. On the left, you see a little bit of a breakdown on the geographical location of the evidence. The majority has been from North America, so that's the US and Canada, a lot from the Netherlands as well, and then here and there another study from across Europe. On the right, you see the types of dementias that were primarily focused on. 9 studies looked at a random selection of different types of dementias or any dementia. 3 were focused on Lewy body, 3 on frontotemporal, 3 specifically on young onset, etc. So that's important for us to know. So we had those 20 papers. They had different findings, different countries, different population groups, different subtypes. How did we pull them together? So we sat down and thought, they might be clustered into kind of 4 themes. Although some of those themes are obviously overlapping, but we thought this might give us a better summary and overview of what the evidence says to date. Now I'm highlighting some of those studies that were included, not all of them, just as examples. The first theme or category that we identified were factors associated with a delayed or a misdiagnosis in the first place. There was quite a bit of evidence on ethnicity as a factor. So if someone was from a minority ethnic background in a predominantly white, high-income country, but I just want to zoom back here again as well. All these countries are high-income white countries. We need evidence from countries that are from lower and middle income backgrounds. That's one of the first limitations of the evidence to date. We need to understand how it's working in Colombia, in Argentina, in India, etc. We also found that with an increased age, more people appear to have a misdiagnosis. Now, we need to treat all of these with very much caution because there is not a lot of evidence out there. So these are indications. We also found that worse cognitive status was linked to a misdiagnosis and multimorbidity, so including depression and mood disorders. So having that present was linked to a delayed or misdiagnosis. Another theme that emerged, or category, was difficulties related to the actual diagnostic process. So some of those studies looked specifically at frontotemporal dementias. And for example, they found that increased age, having a spousal caregiver, living in a rural setting as opposed to an urban setting, and having specific symptoms were linked to correct diagnosis within 1 year, which is what we want. We want correct and timely. I found it interesting to see that living in a rural area was linked to correct diagnosis, because oftentimes we hear that there is fewer services or lack of knowledge, etc. So that's interesting. We also found in a study by Barker et al., 2023, that half of the people included in this analysis received incorrectly a first diagnosis of frontotemporal dementia, 50%. So that has huge implications on their care, on their experiences, but also having them to continue to go through the process of being involved with health and social care services about this. And also receiving a diagnosis of Lewy body dementia was significantly delayed compared to other dementias. Now, this is something we've heard a lot from people who are living with Lewy body dementia and their family carers, that they have severe delays. So it's good to see some evidence, but there's not a lot. This is one study, which supports the evidence of the other 2 studies of Lewy body dementia. But again, those 3 studies are from the US, where diagnosis is done differently. What about getting a diagnosis of Lewy body dementia in the UK or in another European country? So there are clear limitations, but what's already emerging is there are difficulties, and maybe this can help us identify how we can avoid misdiagnosis or tackle misdiagnosis in dementia subtypes. A third one, which was very slim on the evidence side, only 2 studies, and both of them from the US, looked at the economic consequences of a misdiagnosis of dementia. And that's really, really important to look at, because we know receiving a diagnosis, going through the process of care, etc., of dementia, it's a huge economic burden to society, to families, to the person themselves, besides all the emotional impact, of course. But what's interesting is that, as we know, the US has a very different system of supporting people with medical care and medical support than the UK or many other European countries. So whilst the data showed there were some substantial cost implications, another study looked at misdiagnosis via Medicare claims. The second study wasn't very clear, so we put that in as a limitation because the methodology looked a little bit not well explained, and for us, we couldn't really make sense of it. But this one study, which showed substantial cost implications, suggests we really need to do some cost analysis of misdiagnosis in other countries, including the UK. And then I'm moving on to the final theme, category, which was heavily focused on young onset dementia as well, because 3 of those studies fitted in to this section. So the 4th category looked at experiences of obtaining a dementia diagnosis. This category included 4 qualitative studies, And 3 of those looked at young onset dementia. Those 3 studies were conducted either in the Netherlands or in Canada. One of them, from Vliet et al. 2011, for example, showed that 45% of cases were misdiagnosed and received inadequate help. And those symptoms weren't really recognized by the healthcare professionals. And that was a theme throughout those 3 studies: lack of workforce knowledge, lack of GP knowledge on how to identify those symptoms of young onset dementia, and then lack of communication from healthcare professionals to the people receiving the diagnosis. What was also interesting that in Canada, healthcare professionals highlighted some limitations of those diagnostic tests to identify dementia in people of a younger age. But overall, really difficult emotional experiences identified in the evidence to date. The 4th study in this category was from the UK, but again, it shows whilst there's some diversity in geography, there's not a lot of evidence out there, and 3 studies only on misdiagnosis of young onset dementia is not enough. What is the status of this in the UK? So this systematic review for us highlights that there's a significant issue, but it also highlights a lot of other avenues that need to be explored. So there's still a lot of unknowns. There's, whilst there are some, like 3 studies on Lewy body, 3 studies just on frontotemporal dementia, there seems to be a lack of focus on individual subtypes. Each subtype is different, and we need to do more to understand how is that linked to misdiagnosis. More cross-country evidence, so comparing how it works across different countries across Europe, but also more evidence from individual countries, and there should be more evidence from the UK. It's really lacking behind. We need a greater focus on young onset dementia. Economic impacts are under-investigated, etc. This is just a highlight of the issues and a highlight of the statements that we're making in our systematic review. Hopefully this will be published in the next couple of months so you can read it, and we're happy to share this with Tessa and everyone. But I don't like to add something on a very negative note. So what can we do? Can we do anything? Well, besides us as a group applying for research funding to really look into this area more in the UK, and hoping to starting to develop some solutions to misdiagnosis, we also think there can be an avenue of educating health and social care workforce, but also maybe educating people in general about different subtypes of dementia or dementia in general, so that people are more likely to approach their GP in the first place. So one solution that might help, and we've got some very preliminary evidence on this, could be the Dementia Inequalities Game. Obviously, I'm biased presenting this here because we co-produced it in our group and with the Lewy Body Society together. So let me tell you a little bit about this game. It's a board game, and we co-produced it together with people who are affected by dementia directly and indirectly, care professionals, third sector, because we thought all those academic papers, that is our currency as academics. Yes, that's knowledge, but it doesn't really reach the care home professional. It doesn't really reach the GP, the nurse, the occupational therapist, etc., as well as maybe something else. So we do write blogs, we do write lay summaries, we do some videos, we do webinars, we go out to NHS trusts, etc., and to care homes. But we thought, could there be something in there about bringing people together in one spot and discussing and learning about dementia together in a really engaging way? So the Wellcome Trust has been fantastic in funding us, and we could hold some co-production workshops. And that means we sat down with those people together. We didn't have any idea on what this game may look like. We have conducted research in the field, others have done research in the field, We presented attendees with that evidence. We asked them about their own experiences. And then we asked them, if you have a blank piece of paper, where would you even start developing a game? So we quickly moved to the idea of a kind of snakes and ladder approach of a game, where you can either move forward or move backward, which is really nicely illustrating this facilitator moving forward or barrier moving backward process of diagnosis and care. So on the left side here, you see a SURF. You see in the background, SURF Liverpool, which is a support group for people living with dementia and unpaid carers, any age, young onset, late onset, etc., any subtype, and they meet every month. And we launched the game on the 1st of September during World Alzheimer's Month last year. And here in the middle, you also see some cutouts of the different barriers and facilitators that people themselves have highlighted. I'll show you the game on the next slide, but I just wanted to highlight already that we are currently adapting the game in Ireland, in Germany and Portugal, and we're reaching out to other countries to adapt the game to be linguistically correct, but also, for example, Admiral nurses or dementia care navigators might be very UK specific. They may not exist in the Netherlands or in Sweden or Norway. So we're working on that. We've also just completed our second evaluation of the game. First of all, we went into a museum in Liverpool in October and tested the general public by playing the game. And second, we've just tested over 300 students at the university who are doing courses in nursing, psychology, occupational therapy, etc. And we found, giving them a very brief before and after test about dementia knowledge, that playing the game, which takes maybe 45 minutes, maximum 60 minutes, not longer, can significantly improve your knowledge about dementia and dementia inequalities. So there can be a huge area here for workforce education as well, in a social environment where people can share their experiences. Now, this is the actual board game. And I just want to stress again, we wanted something that brings people together in person and not a digital app or anything, because we want people to socialize as well and talk. And also the game offers the opportunity to share your experiences about dementia, about supporting someone, about caring for someone. During the workshops, people were very persistent on having a pre-diagnosis and a post-diagnosis half of the game. You can play this between 2 and 6 players, roll the dice, and if you come on any of those scales, those inequality cards, you pick a card, and we have about 70, 80 cards for those, and they will either tell you you are aged 54, your GP does not recognize you might have dementia and you're not being referred. Please move 2 steps back. Or you come across a card that says you have an unpaid carer who knows how to navigate the system. Please move 3 steps ahead. All those different inequalities are in there. You can also come across one of those general question or activity fields. So then one of your opponents, other players, picks up a card and asks you a general question about dementia. For example, what are the 12 modifiable risk factors of dementia? What are some of the key symptoms of Lewy body dementia, of frontotemporal dementias? How many people live with dementia in the UK? All these sorts of things. Now, the game is available via the Lewy Body Society shop, and all the profits go back to charity or public outreach work with people with dementia or their carers. So that's the game. We hope this will be a suitable solution in one way, a sociable solution to increase knowledge. And maybe that might lead to reduced cases of misdiagnosis, even if it trickles down a little bit. We're not having high hopes, but it's really about general education and knowledge raising. And to finish off my talk, I don't even know how long, 30 minutes, that was good. I want to raise awareness about our new network. So we've been funded by the Alzheimer's Society, the NIHR, and the ESRC for 5 years, which commenced on the 1st of April, on the INTERDEM Network Plus, so Equalities in Dementia Network. Who are we? We are just under 20 members at 7 different universities across the country, you can see here. We are leading this from Liverpool, co-leading with Newcastle. We have different charities involved, such as Dementia UK. We have an NHS trust involved, and other organisations and unpaid carers, etc. And we're hosting events every quarter to find solutions to inequalities in diagnosis and care. We will also offer research internships for health and social care professionals and people working in charities. If you have an idea that could tackle an inequality in dementia, please come to us. We're really keen to hear about it, and maybe you get an internship out of it or a small project funding as well. Now, we're launching tomorrow. Over 130 people have signed up. All these events will be in person, but we will also set up a webinar series very soon. So I appreciate that's tomorrow. The next event will be on the 18th of September at Manchester University. And on the 9th of December, we will be in Newcastle. And then afterwards, we will move across the country again. But just a call for anyone who'd like to learn more or meet people or get something out of it, please join us. And just to say, this is our team who's done the review, and happy to take any questions.
Thank you very much, Clarissa. That we need to have some time to take all that on board, I think, and I'm really looking forward to being able to read the publication. That's great. We do have some questions, if that's okay, so I'll just launch straight in with those. Actually, I won't. I'll just ask you, very early on, you used an abbreviation, was it OED or something like that very early on in your slide? It was a report or just to explain it.
Yeah, sorry, OHE, Office of Health Economics, I think it is. Yeah, they did a joint report with the Alzheimer's Society.
Okay, thank you very much for that. Right, let's go to the questions then. So first off, is there any evidence that a diagnosis of dementia has significant effect on outcomes compared with those people with dementia who haven't been diagnosed?
Well, first question as a researcher is what outcomes?
Okay. So
it might, yeah, I can't answer unless I know the outcomes that the person is referring to.
Should we assume that there are outcomes for the individual and for the family, and should we assume that they are to do with the way they live, the quality of the life that they live from the point of diagnosis onwards? And if that's incorrect, then the attendee can correct me on that. But should we start with that? And is it one that you feel that you can answer?
As far as I'm aware, I do not think there's any evidence out there on that, because it's also really, there is evidence on people with cognitive deficits or memory impairment that is not classed as dementia, and people living with dementia. But for us to know they have dementia but they're not diagnosed, we as researchers wouldn't know that, because we tend to find people often by going to a memory clinic or to a GP or nurses, etc. But it's interesting to think about it, different outcomes.
Yes, and I think you're very much answering correctly from a researcher's point of view, because many people with young onset dementia and family members express their own benefits once they the improvement to their quality of life, if you like, once they have a diagnosis. And of course, that's their report that's coming from them. So thank you for that. That was a bit of a tricky one to start with. Is there likely to be research in the UK for misdiagnosis in for people with young onset dementia and other dementias, other types of dementia? Do you know of any?
Well, we've just submitted a grant application, so do keep your fingers crossed, because that's precisely what we want to research and look at, including young onset dementia, including different subtypes. So
different types and to include young onset. So that would be really interesting for us to follow through on. So hope you're successful with that. This is appreciation from Jeremy. Thanks very much for an interesting, important talk. Did you find any literature on people who'd been diagnosed incorrectly with dementia and were later re-diagnosed with a non-dementia diagnosis? And we are aware that this happens as well.
We expected to find some based on our discussions with people with lived experiences and a lot of healthcare professionals, but we didn't find any evidence about that form of misdiagnosis.
Okay, if there's any follow-ups, do put them in the Q&A for us. Are there any solutions being gathered from this research on how we can support people in gaining a diagnosis sooner? Anything from the research?
Definitely, in approaching, yeah, we definitely still need to increase workforce knowledge and healthcare professional knowledge about the different symptoms and age, etc., especially age. I think it is a multitude of awareness raising approaches from different organizations, a game, a campaign. It's all these things, but also, I suppose, maybe government bringing it in front of the House of Commons again, getting a debate going about young onset dementia, different types of dementias. So the all-party parliamentary group on dementia is doing really well. Hopefully with the new government in place, it will continue and maybe reach out more to raise awareness.
Thank you. Good point. And it is an opportunity for us to bring it to, as a priority again, isn't it? The new government and what the OPPO and the APPG. What is the age group that one can be classified to have a young onset dementia?
Below 65.
Below 65. And that's
the pass the test, Tessa.
Is that on the Inequalities Game?
Yes, it is. Yeah.
And it is an internationally agreed consensus, isn't it, in terms of the under 65?
Yes and no. So when we do a lot of research on mental health as an umbrella term with older adults in low and middle income countries. So we just completed a 3-year project with older adults in Colombia and their carers. And in low and middle income countries, because of reduced life expectancy, aged 60 is categorized as being an older adult. So we would expect in those countries it's 60 and below.
Yes, thank you. You've corrected me because I think it's a European international consensus, isn't it? Yes, that's an interesting thought, isn't it? That it would, and it makes sense that it would be lower perhaps in other countries. So have you looked at research into misdiagnosis where a person, did we not have something similar to that? Was diagnosed with dementia and then has the diagnosis taken away?
We've just talked about that, I think.
Is that a repeat? It feels as though that might be a repeat one, that one. Let's move on. Do you have any knowledge of medications being prescribed with more successful outcomes in terms of quality of life, arresting cognitive decline post-diagnosis? Is that something that you feel?
Can't answer that. I'm a neuropsychologist by background, not a medic. But as a neuropsychologist and psychologist, I urge all the other non-pharmacological treatments that are available, exercise, cognitive stimulation, and all these things, healthy nutrition.
Thank you. Did your review look into familial dementia? Pick up on any of?
Not well. We did have. Do you mean Alzheimer's disease dementia?
Well, it could be any familial dementia, so related to Alzheimer's or related to frontotemporal.
We only looked at what they were detailing in the methods, which can sometimes be quite limited as well.
Yeah.
So it's something for us as well, if we get the funding, to be really detailed about the diagnostic criteria.
Because that's going to, one would think it would affect the speed at which accurate diagnosis might be given if it's a familial source or cause, I should say. Based on your findings, should the NICE guidance on dementia diagnosis be revised?
I am not sure, because I do think the evidence base to date is really slim, as we've seen in that systematic review. It highlights a lot of areas that are an issue, but we need so much more evidence. So possibly at this stage, maybe not, but definitely in the future.
Another one to keep working on and keep an eye on in terms of the future then. Do we think there are new opportunities when and if the new drugs come into play, as there will be greater emphasis on scanning? Is that going to provide new opportunities in terms of the accurate and timely diagnosis?
Certainly identifies a need for more accurate and timely diagnosis, because as far as I'm aware, the new drugs are only suitable, is it for Alzheimer's disease dementia?
I believe so, but please attendees correct. Yeah, it is.
Yeah. So let's just imagine someone gets a diagnosis of I don't know, vascular dementia, or that they wouldn't get any. Yeah. Just imagine if someone gets a wrong diagnosis and is then not able to access the drugs, although they actually do have Alzheimer's disease dementia and could be prevented further progression for 2 years or something. So there's almost a race now to get the diagnosis properly correct now.
Okay, thank you. I think we're at the end of our questions, unless there's, let me just check. Okay, I thank you for explaining the inequalities game. That does seem, it's another way, isn't it? It's another way of raising awareness and in a sociable way, as you say, and to encourage some learning in various people who are connected with the support of people with dementia. So that's great. Thank you. I was just checking if there were any other questions. I'm going to close now, and thanking you very much, Clarissa, for your presentation today. It's really interesting, and so good that that those findings, you've pulled together the findings from all those reviewed from all those studies, and identified there's a lot more to do to be able to make some progress with improving diagnosis and reducing misdiagnosis, which is good for everybody concerned, really. So, as Clarissa said, we can't share the recording, as would our usual practice be, and we can't share the presentation yet because it's not yet published. So as and when we can, we will. We'll commit to doing that. And thank you, Clarissa. And if you could alert us, that would be great. We'll make sure that we put a link to the inequalities game in the follow-up email if we've not been able to put it in the chat. So that's great. But thank you very much, Clarissa. That was really interesting. And thank you very much, all attendees. Oh, there's a question around the inequalities game, will it be available suitably adjusted for Canada?
We're currently only allowed well, it's easier for us to send it within the UK, but we can sometimes make some, if we can discuss it with individuals. So I think the best thing is if anyone would like to drop me an email and we can have a chat about it. I'm sure there's a way of sorting this, yes.
Okay, so can we make sure that Clarissa's email is on the chat if possible? Thank you very much.
I can't write in the chat, I'm sorry.
No, I think perhaps Kate can do that, and if not, we'll put it in the follow-up email. So just to quickly let you know that we have a summer break, and we will reconvene webinar-wise in October the 16th, and we're going to be focusing on primary care and young onset dementia for that webinar. And then it'll be November the 19th, will be a collaboration with the Netherlands Young Onset Dementia Centre again. And for that, we're going to focus on children and younger people, the support of children and younger people who are affected by parental young onset dementia. So just going to check the messages, make sure that there's nothing I need to. Lots of thanks for a very informative webinar, Clarissa. Thank you very much. So I'm going to close the webinar now, and thank you all for attending.